Good afternoon and welcome everyone to our virtual forum in partnership with the CDC. My name is Danny Carlson. I'm NASP's, the National Association of Elementary School Principals, Associate Executive Director for Policy and Advocacy. We really appreciate you joining us today. We think this is a timely and frankly much needed conversation in the field right now. We're very much looking forward to doing a deep dive on some of these really sort of tough issues that schools are facing at this moment. Things like safe school reopenings, COVID testing in schools, and in-school mitigation strategies. First, we really appreciate the CDC for joining us today. We're looking forward to their insights and recommendations to help education leaders navigate what can only be described as really choppy waters right now. Let's not mince words. It's a tough time for folks on the ground working in schools. So we're really looking forward to the CDC helping us to cut through some of this noise and to help you all, those making the decisions on the ground, better understand these complicated issues so you can make the most informed decisions. I'm going to introduce the CDC team in a minute, but I first wanted to introduce NASP's Executive Director, Dr. Earl Franks. He leads our organization, which comprises 14,000 principals from across the country.
Thanks, Danny. And on behalf of the NAESP organization, I just want to thank all of you for joining us for this highly informative forum today. Special thanks to our colleagues at the CDC for being with us to share this important information. So thanks to all, and we look forward to a good forum.
So why is this forum needed at this moment? It's clear that education leaders, superintendents, principals, teachers, even parents, they need science-based recommendations on the issues surrounding, on issues such as reopening schools, protecting students and staff, and responses when and if individuals become infected in buildings. I don't need to remind you all that we're in the middle of a pandemic, and so these decisions truly have life and death impacts. All that to say, we're very happy to hear directly from the CDC today. We're honored to be joined by Dr. Greta Massetti, who leads the Community Interventions and Critical Populations Task Force on CDC's COVID-19. Her presentation will focus on what constitutes safe school reopenings, including which factors schools and communities should consider testing and tracing in schools, and what are effective in-school mitigation strategies. Before we jump into the presentation, though, I wanted to do a quick poll to see who's out there in our virtual crowd. So to kick things off, the first question is this. If you could, there should be a poll popping up in a minute. There it is. If you could select which region of the country you're joining us from today. We're just going to have a quick, just 20-30 seconds just to get a pulse here. Okay, great. So a good mix. Looks like a handful of folks, 27% calling it from the south, 10% Southwest, 8% the West Coast, 11% the Midwest, 32% the Northeast. That seems to be the winner. And then other, so other parts of the country or potentially other parts of the world, clocks in at 13%. Okay, one more question before we begin. Please identify what setting your school, so for those in the audience who are practitioners who work in schools, please identify what is your school setting. All right, so 22% work in urban settings, 47% suburban, and 31% rural. All right, great. So thanks for participating. That's really helpful for us. It's just always good to kind of know who's out there. Great, and so now let's jump into our presentation. Dr. Greta Massetti is the lead of the Community Interventions and Critical Populations Task Force on CDC's COVID-19 response. CICP, as it's known, is responsible for developing guidance and practical tools for community mitigation activities and attending to special populations, particularly those disproportionately affected by COVID-19. CICP is engaged in strengthening technical assistance efforts to states and communities, as well as through key partners to optimize community mitigation efforts. When not engaged in COVID response, Dr. Massetti is a branch chief and senior epidemiologist in the National Center for Injury Prevention and Control at CDC. Dr. Massetti is joined by her deputy for community interventions, Dr. Chris Jones, and Ms. Jessica Lee of CDC's Health Systems and Worker Safety Task Force. Dr. Massetti, take it away.
Great. Thank you so much for having me, and I'm really glad to join you today, and I'm so interested to see all the many different places around the country and around the world that are represented among our attendees. And, you know, I think every school is unique and every context is unique, every school context is unique, but then there's also a lot of commonalities and similarities. Today, I'm going to talk a little bit about where we are as of today with the pandemic, share some data and statistics. I'm going to talk a little bit about some guidance and considerations for K-12 schools that we've been working on that's available. And then I'm going to touch on a few other topics that are relevant to this particular population. One thing I want to mention is I know it can sometimes be difficult to navigate CDC's website, and in particular, we have released thousands and thousands of web pages since March. And so one of the things that I've done on our slides, which can be made available to anyone who's interested, is that at the bottom you'll see there's red font. There's some keywords in red font that you can use as Google search terms to try to find the information specifically. Of course, we're also happy to share web links for anything you're looking for. Next slide, please. All right, so let me share a little bit about where we are. Next. Nationally, indicators that track COVID-19 activities indicate that COVID is continuing to decline or remain stable within the United States. However, there are some regions that are showing different activities. As you can see from the slides, in the last 7 days, there have been more than 306,000 new cases of COVID-19. And of course, a couple of weeks ago, we passed the grim milestone of having more than 7 million cases and over 200,000 deaths to date. Next slide, please. Relevant to the school context, I like to kind of provide a little bit of understanding of how some patterns have changed and emerged over the course of the pandemic. So you can see these are the trends in case incidents by age group. So you can see the different bands represent different age groups. And early on in the pandemic, in March and April, people who were 45 and older, that's the green band, the dark blue and the purple at the top, represented the majority of new cases. And as time has gone by, now we can see that those older people represent a smaller proportion of new cases each month. Whereas we're seeing growing representation among people who are in that young adult age group, those 18 to 24-year-olds. You may have seen in the media, there's been a lot of talk around outbreaks on college campuses. And you're also seeing in that gray and orange band a little bit of growth among, in representation of new cases among children who are school age, those 5 to 11 and to 12 to 17. So I'm going to focus a little bit more on that because we are seeing that early on, cases among children were not very common, and now we're seeing them emerge more commonly, although there's still a relatively smaller proportion of the new cases. I wanted to also highlight a recent article that was published just last week where we looked at demographic characteristics among school-aged children with COVID. So this study looked at 277,000 laboratory-confirmed cases of COVID among school-aged children in the United States. And these were all cases from May until mid-July. And what we found from May until August. We found a few things. One is that there were twice as many cases among adolescents, the 12 to 17-year-olds, as children, the 5 to 11-year-olds. And that is consistent with some recent data that suggests that younger children may be less susceptible. So if they're come into contact with someone who has COVID-19, may be less likely to get sick. And then teenagers, and then compared to adult as well. We also found that there were children who did get COVID were more likely to get sick if they had certain underlying medical conditions, and those included things like overweight or obesity, and asthma, And also we found that as we see with adults, there are children who have severe disease are more likely to represent children who are certain racial and ethnic minority populations, and particularly those who are Hispanic or Latino and those who are Black. And so we're seeing these racial and ethnic disparities emerge early on. Next slide, please. So this leads us to kind of what should schools do? We know that there's lots of questions that you probably have and questions that you are being posed by your teachers, your parents, stakeholders. And this is where CDC kind of compiles all of the information and the science and the data that we're seeing evolve very rapidly. And we kind of put it together and share guidance and considerations for K through 12 schools and stakeholders to think through. I'm going to talk about a few of the highlights. In the past several months, many partners and members of the public have been asking CDC, how do we decide when it is safe to open schools for in-person learning? And of course, there's no easy answer, and there's no single indicator that can tell us that, and one indicator that applies across all schools and contexts. And we take lots of variables into consideration. Also, when making decisions when to open schools for in-person learning, it is important to understand that COVID transmission in the surrounding communities, as you all know with your experience in schools are not in a bubble. They are embedded within the context of the communities that they are placed in. So that information around risk of community transmission gives us a sense of the possible risk of introduction and transmission of COVID-19 within the school. In mid-September, CDC released indicators to help schools make these ongoing decisions about in-person learning as local conditions evolve throughout the pandemic. When coupled with local data about community spread, these indicators are an important tool that local health officials, school administrators, and communities can use to prepare, plan, and respond to COVID-19. We have some core and secondary indicators that help schools make these decisions. And one thing that we like to emphasize is that the reason we call them dynamic school decision making is because we recognize that this is not a one-time decision, that it's as COVID rapidly evolves in communities, these sometimes are decisions that have to be revisited over time. Next slide, please. So here are the core indicators to inform in-person school learning. There are 3 core indicators. 2 of them are measures of community burden. One is the number of new cases per 100,000 persons within the last 7 days. And you can see that that's the top row on the slide. And there are kind of 5 levels or 5 bands of risk, from lowest risk of transmission in schools to highest risk of transmission in schools. And this gives you an idea of how many recent cases have there been in the last 2 weeks in this county or in this community, and gives you an idea of how much COVID is spread within that community. We also pair that indicator with the percentage of diagnostic tests that are positive within the last 14 days. That gives you an indication of how many cases of illness are we catching. If percent positivity is very high, it means that testing has not reached most people. So there may be people who are sick, who are not getting tested, not quarantining, and more likely to spread. We also want to emphasize that those 2 indicators must be paired with a self-assessed measure of the school's ability to implement key mitigation strategies. And those are the consistent and correct use of masks, social distancing to the largest extent possible, hand hygiene and respiratory etiquette, meaning coughing into one's elbow as opposed to the hand, cleaning and disinfection, and contact tracing in collaboration with the local health department. This gives us an idea of what is the capacity within the school to be able to mitigate any potential issues. These measures give us an idea of both the incidence and spread in the surrounding community and not necessarily in the school themselves. And this gives you an idea of, depending on where a school community is set, that the school might be at medium, higher, or highest risk of transmission. What we emphasize is that this does not necessarily mean that schools must close for in-person learning. You'll note that the chart doesn't have any kind of cut point that tells you, because it really depends on the extent to which those mitigation strategies can be in place, and also kind of what the current context is around the school, that those are supposed to inform a decision. They don't make the decision for you. One important note before I move on, these indicators were developed with in-person learning in mind. It includes all classes and activities conducted during core school hours. It does not explicitly include or exclude extracurricular activities like sports or theater or clubs, because those can vary so much based on risk for transmission. And so those are kind of an added consideration that schools must take into account as well. In addition to these core indicators, there are a number of secondary indicators. They are not necessarily to be used to make decisions. They just provide additional context. And there are things like how many hospital beds are occupied in the local community, and whether there's any local community outbreaks. Next slide, please. So one thing is that's really important to emphasize is that regardless of what the indicators determine, it is critical to ensure the use and layering of comprehensive mitigation strategies. And those are the ones that I mentioned before: masking, social distancing, hand hygiene. One way we've been communicating with schools about this is that we kind of describe a layers of Swiss cheese approach, right? The idea is that it is unrealistic to expect that any one school or any one strategy will be implemented 100% all the time. These are young children that we're talking about, and they are kind of messy community contexts. So there are times when a child might take their mask off, or when physical distancing is not possible. The idea is that, you know, each layer, each strategy is one layer, and if there's a hole and there's a misstep in the implementation, there's those other layers that can provide protection, so that there's mutual coverage. So if there's good cleaning and hand hygiene, if there's good social distancing and use of masks whenever possible, and contact tracing, that those, if anything isn't implemented as intended, those other strategies should be providing that corrective protection as well. Next slide, please. So my next few slides will give a little bit more information on some of these particular specific strategies. When used consistently and correctly, along with other important mitigation strategies, masks are important to help slow the spread of COVID-19. We recognize that there are specific instances when wearing a mask may not be feasible. And in these instances, parents and caregivers and teachers and school administrators should consider adaptations and alternatives whenever possible. And of course, we want to acknowledge that there may be times when masks should not be used, and that includes children who are younger than 2, or anyone who has trouble breathing, or is unconscious, or incapacitated. CDC recommends that people, including teachers, staff, and students, wear masks in public settings as able when around people who live outside of their household, especially when other social distancing measures are difficult to maintain. The table on this slide, which is also available on our website, contains examples of some but not all situations schools might encounter. As K through 12 schools reopen for in-person instruction, it is important to have systems in place for the monitoring and evaluation of COVID-19 mitigation strategies. This helps you assess, and I can imagine for those of you who are elementary school principals, one thing you'll want to know is, how well are we doing? You know, is masking causing a problem? Is physical distancing being done well? And in which places are we struggling to do physical distancing? So CDC has developed a resource that helps provide example evaluation questions, indicators, and data sources to help you monitor and evaluate the implementation and impact of COVID-19 strategies in your schools. Education and public health agencies in collaboration could use these resources to develop a monitoring and evaluation protocol and determine a scope feasible for your particular situation. Testing to diagnose COVID-19 is part of comprehensive strategies, and it should be used in conjunction with promoting behaviors that reduce spread, like social distancing, maintaining healthy environments like ventilation, and preparing for when someone gets sick. We encourage schools to work with public health officials to decide if and how to use testing and when it is appropriate to refer an individual, a student, a teacher, a staff member for testing. Of course, school-based testing of students should never be conducted without appropriate consent from a parent or legal guardians. As many of you may have seen in the news, there are these new rapid antigen tests that are becoming more and more available. These types of tests can provide results in as little as 15 minutes. So we are working right now on some considerations on the appropriate use of testing in K through 12 schools settings for COVID-19. We don't have any regulatory authority over testing, so the idea of these considerations is just to provide school officials some helpful information to help them understand, is testing in school the right fit for me? If not, what might be a good strategy for partnering with my local public health department to refer for testing and provide testing, making testing available to my school community. This document should post on our website soon, hopefully within the next week or two. Next slide, please. Case investigation and contact tracing are also essential interventions in a successful comprehensive response to COVID-19, and they should be implemented along with other mitigation strategies. As schools resume for in-person learning, case investigation and contact tracing with staff, teachers, and students should be anticipated as a crucial strategy to reduce transmission once a case is identified. School involvement with the official health department, case investigation, or contact tracing process may vary depending on federal, state, or local laws and regulations, as well as the authorities and capacities of health departments. In general, most health departments have done contact tracing for a long time for a variety of diseases, so they have really good expertise in this type of area. Next slide, please. In addition to the guidance and considerations that I've talked through today, we have a range of K through 12 guidance and tools under the development, and we have a few other tools as well around holidays, parenting that may be useful for schools to make available to families as well. Next slide, please. And you can probably just go ahead and skip to the next one. So I'm going to go ahead and talk to you a little bit about some of these additional tools that we've released. So as many of you know, schools are essentials to meeting the nutritional needs of children, with many consuming up to half their daily calories at school. Nationwide, more than 30 million children participate in this National School Lunch Program, and nearly 15 million participate in school breakfast program. There are several mitigation strategies that schools may implement while providing this critical service to their students. So we have some tools available on our website around that help kind of make decisions around avoiding offering any self-serve food or drink options, and how to adjust the offerings to make sure that we're reducing the risk of transmission through those lunch and meal programs. CDC also has information on ways in which youth sports organizations can protect players, families, and communities and slow the spread of COVID-19. Administrators of youth sports organizations can consult with state and local health officials to determine if and how to put into place these considerations. Each community may need to make adjustments to meet its unique needs and circumstances. And generally speaking, kind of our risk framework suggests that the more people a child or coach interacts with, the closer the physical interaction and the more sharing of equipment there is by multiple players, the longer that interaction, the higher risk of COVID. So you can imagine different sports fall in different spots along that continuum, right? So basketball confers a different level of risk than outdoor soccer, for example. Next slide, please. COVID-19 can also affect children and young people directly and indirectly. Beyond getting sick, many young people's social, emotional, and mental well-being has been impacted by the pandemic. Trauma faced at this developmental stage can continue to affect them across their lifespan. Some of the challenges children and young people face relate to changes in routines, breaks in continuity of learning, breaks in continuity of healthcare, missed significant life events like birthdays, and lost security and safety. We've developed a COVID-19 parental resources kit to help support parents, caregivers, and other adults serving children and young people and recognizing children and young people's social, emotional, and mental health challenges and ensure their well-being. One of the resources included in this kit is the board game on this slide, where as a family, you can each pick a masked character and follow the path scanning the QR codes to learn tips for a healthy school year. We also have some considerations for fall and winter holidays, as many people in the United States begin to plan for the holiday celebrations. We've put together information to help protect individuals, families, friends, and communities from COVID-19. When planning to host a holiday celebration, people are encouraged to assess current COVID-19 levels in their communities and determine whether to postpone, cancel, limit the number of attendees, or plan events based on kind of what might be the best ways to mitigate risk. Next slide, please. The next holiday on everyone's minds is, and especially for among school-aged children, is Halloween. Contrary to what the headlines may have reported, CDC is not canceling Halloween. We will need to be creative in how we celebrate as many traditional Halloween activities and ensure that we kind of emphasize and take the opportunity to celebrate in ways that are lower risk and avoid things that are higher risk activities. There are several safer alternative ways to participate in Halloween, some of which are listed on this slide. In all scenarios, if someone has COVID-19 or may have been exposed to someone or come in contact with someone with COVID-19, that person should not participate in in-person Halloween festivities and should not give out candy to trick-or-treaters. Next slide, please. And you can just jump to the next one. So just to summarize and kind of revisit some points, the guidance and tools that we make available are really to help local school officials, school administrators, communities make decisions based on what is the right fit for their local context, their communities, and their needs. We provide resources and information. And one thing that I didn't get a chance to mention today, but I'm happy to talk about as well, is we don't just put out guidance and provide information. We also make technical assistance available to schools and communities as needed. We have several technical assistance teams that would be happy to work with schools. They've done some fairly innovative things, such as virtual school walkthroughs, where schools use an iPad to walk around the school and show our teams what they're doing to try to mitigate risk, and we can give advice and suggestions. We've reviewed materials and plans. We're available to help translate this information to the local context and help you make the best decisions based on your community's needs. So I think that kind of concludes my presentation portion, but of course we're happy to answer any questions that you might have about any of CDC's work.
Yeah, thank you, Dr. Massetti. That was really great, really informative, a lot of information, and it's just really, really helpful stuff. I'm going to follow up with just a couple questions, and then we're going to use the bulk of the rest of the time to try to get at the many questions in the chat box. Folks have a lot of questions. So, but I just want to first ask, just kind of big picture, you know, what should it look like just in terms of an ideal situation? And of course, every community and district and school is unique. But what should it look like just in terms of coordination with local health departments around making decisions around school reopenings and, you know, monitoring the sort of, you know, the data in the region about if schools should stay open and all these things? What should that sort of relationship look like?
Yeah, that's a great question. So one point is definitely in this context, I would encourage any school official to reach out to their local health department and establish a communication channel. You want them to let you know if they're noting something and they're seeing something in the community that they think you should know about. And likewise, you want to be able to pick up the phone at any time and reach out to them if you have questions or need advice. They're really kind of the experts on the local community. And then kind of what that looks like really depends on what the unique needs might be. What we're seeing, you know, health departments have developed phenomenal websites across the country that we're tracking every day to look at, they have dashboards on the number of cases, they're tracking, providing assistance to local communities. So they can tell you kind of what types of assistance they can provide, what collaborative projects might be the best fit for your community. So I really encourage that bidirectional communication.
Great, that's really helpful. One more question, and then we'll jump into the crowd questions. So what is kind of your sense, just in terms of across the country, how schools are sort of handling something complicated like contact tracing, and just sort of in cases, in examples where there are cases in schools, and sort of what schools are doing? Is it happening at all? Does it depend on the sort of grade level? What's your sense of that?
Yeah, so I think that's something that we've been thinking through a lot, because of course it touches on issues around privacy, FERPA, all of those types of things. So that's really where an early conversation before an outbreak occurs, an early conversation with the health department can help understand, like, what is the plan? Like, schools maintain classroom lists, they have contact information. Do we need to get consent in advance in the event that an outbreak breaks out? So I think that's where kind of having those plans in place early on, starting those conversations early on, can help address, so that when something happens, you're not left to kind of scramble and think about, oh wait, what do we do? Who do we call first? Where do we start? Chris, I don't know if you have more to add on that particular question around contact tracing.
No, I think you covered it, Greta.
Okay, thanks. Well, let's dive into some of these questions. We're going to do our best to try to get to as many as we can. For the ones that we do not answer, we're going to go through the chat box, and any ones that we do not answer, we're going to compile a list, and the CDC has offered to answer those questions in a Q&A document. So we really appreciate that. Well, we had a question here in the chat box. There was this. There was some sort of spikes and sort of declines in July and August with some of these cases with kids, and I think that maybe it was the 5 to 11 age group. What's your sense of kind of what happened kind of late summer into the fall? Is there any attribution to schools reopening and spikes in cases in this?
We don't have concrete data to really be able to pinpoint what exactly led to some of those some of those increases. Certainly, I know as a parent, when schools first closed in my community and my children were staying home, there were many months where they didn't come into contact with their friends or physical contact or with others outside of our home. And so I think as time went by and people kind of went out into their communities, sometimes it was exposure in schools, or it could have been play dates or other settings. We also have seen that test positivity among those young children was quite high, and is now starting to decrease, which suggests that at least in some of those days when we're seeing increases among children, that maybe testing wasn't reaching kids. Like, older people were getting tested more readily, but especially if children had very mild symptoms, maybe parents weren't thinking that they needed to be tested. And so I think we're doing a better job at reaching children with testing as well. Are there other questions?
Yeah, we have a lot of questions here. I'm just going to start at the top, and we'll get as many as we can. Gabriel wants to know, how do the 5 to 11 age group trends look in regions that have seen predominant in-person instruction versus regions still largely in a distance learning model?
That is a question that I would love an answer to as well. So one of the challenges that we've encountered is that we're trying to get better information on what are schools doing, which ones are open, which ones have hybrid learning. But unfortunately, that information is not collected comprehensively anywhere. There isn't any website, it's not reported to the Department of Education. CDC doesn't have a way for schools to report data on their status. So we're working on identifying some dashboards we can use to see which schools are open, which schools are still mostly closed, and so that we can kind of map on what do we know about outbreaks onto that information, but we don't have the answer to that question yet.
Another question from Matthew. What do you consider the most dangerous location on school campuses for potential transmissions, and thus where we need to be especially vigilant?
That's a great question. I don't know, Chris or Jessica, do you have thoughts on where you'd start with this one?
So this is Chris. I saw that one come through, and I think, I think where we're definitely recommending focusing on the classrooms and cafeterias where there are students together. I think in the chat, I also saw conversations about restrooms, and I think we would agree with the discussion about within restrooms trying to limit restroom use to certain classrooms, or whenever possible, trying to minimize that any sort of unsupervised or uncontained group contact. So I do think that those areas are probably the bigger ones. I do think that there's more work to be done on sports and the after school activities. I mean, obviously the after school activities are limited, but as it relates to sports, I think we're working closely with our other federal colleagues to better understand what sort of parameters should be put in place there. But I think those are other areas when there are groups of students and teachers together, and where it's harder to keep that 6 feet distance.
This is Jessica, and I'd like to also add the nurse's office and potentially wherever symptomatic students are kept isolating while waiting for pickup or discharge, or your isolation rooms. Over.
Another question, do we have available data related to socioeconomic vulnerabilities among children population infected with COVID-19?
I saw that question and I was trying to think. I don't think that we do have data that suggests that among a general population, primarily adults, individuals who are socioeconomically disadvantaged are more likely to get COVID, and if they do have COVID, they're more likely to have severe disease. I don't think we've done that analysis among children. I did speak to kind of the racial and ethnic disparities, but I don't think that was on socioeconomic disparities. Chris, do you know whether that we've done that yet?
Yeah, I don't, Greta. We can follow up on that one though.
Yeah,
that's a good question.
Okay, we had quite a few questions on masks. Let's just sort of go on the subject of masks sort of overall, and then there was some follow-up questions about, in terms of dividers and barriers, and if it is a divider and a barrier, is that a stand-in for sort of mask wearing? How do all those things kind of relate?
Yeah. So we get that question a lot, and that's in terms of like defining. You define a close contact, which is somebody who was within 6 feet or fewer for at least 15 minutes. And so we have had schools and other communities ask us, what if they were both wearing a mask? Could they be closer, or are they not a close contact? So that recommendation is based on very specific data that was done using kind of this sophisticated modeling that CDC has done with using these mannequins. And so we are very confident to say that the most protective thing is, regardless of whether they're wearing a mask, you want to be able to isolate and quarantine contacts that are within that 6 feet. We don't yet have data to suggest that if they were wearing a mask, it's not so bad. We don't want to make that recommendation yet because we just don't have the data to suggest it, but we're working on it. We have a few different studies that are in progress right now to try to better assess if both individuals were masked. Is that, might that distance be smaller? If there's a barrier, might that distance be smaller? But we're working on it. We just don't have it available.
Just to follow up on that, Greta, there's a couple of questions dealing with face shields in place of masks. What's the policy or the regulation or advisement on that?
Yeah. Looking at all the data of all the different types of masks and face coverings and all kinds of things that they've looked at, they've really been able to pinpoint that there's several features of masks that make them particularly effective. One is if the mask goes under the chin and it covers the chin fully, and if it, another is if it goes all the way over the nose. So one of the concerns with face shields is that it does leave a lot of space open, and so it does seem to be more likely to spread COVID. Face shields generally are suggested in healthcare settings. Jessica may be able to speak to this a little bit more for situations where you have healthcare providers wearing personal protective equipment, using a mask with a face shield on top. I don't know if you have more to say on that, Jessica.
No,
but it's really not an either or. It's, you know, masks are definitely more protective than face shields.
So on that topic, we had a specific question on whether or not gaiters are allowed to be used by students, and those are the, you know, the things that kind of cover the neck and that people pull over. So do those work?
There was a fairly controversial study that was came out a little while ago by, I think, Duke University, that suggested they were spreading more, and then there was more updated data that suggested they might not be as bad. So in general, some of the features of masks that I mentioned, one of them includes that if there's thicker woven material rather than like the t-shirt style, the thicker material is better, and 2-ply is better than 1-ply. And generally, gaiters don't have those features. That doesn't mean that they couldn't, but I think some of the more recent data is that they're not as effective, but they're also not necessarily harmful.
Okay, thanks. That's very helpful. Let's stick on the in-school mitigation strategies. Megan asks about daily temperature checks. Is that an effective strategy for mitigation?
So generally, CDC does not recommend symptom screening, including daily temperature checks, just for a number of reasons. One is that they're not a very protective strategy, because we have seen in a number of cases that a lot of people are shedding COVID before they become symptomatic. So it gives you kind of a false sense of security that if someone has a temperature, like that doesn't mean that if someone doesn't have a temperature, that doesn't mean they're not transmitting. And it creates complications in terms of logistically to have somebody who's standing in a hallway having to take temperatures for all kids. It leads to people having to stand fairly close to people who may be shedding virus. So for those reasons, when we've looked at studies and evidence, you know, there's a lot of missed infections with daily temperature checks, and then there's also a lot of kids who seem to have a temperature, but it may be just that they're overheated, or they have some other symptoms and don't have COVID, and so they're not super useful.
To follow up on the mitigation strategies, we've had several questions regarding school ventilation systems, HVAC standards. Can you speak to that?
I'm going to ask Chris to speak to that.
Yeah, so I think I did see one of the notes that the ventilation systems are listed in the secondary mitigation strategy. So it's not that we don't recommend, you know, addressing that. I think it's not highlighted in the core list of the indicators that that Greta mentioned earlier. So just for one clarification there, that is something to consider. I think there is some work being done with our other colleagues in NIOSH and elsewhere to try to assess what's feasible around the HVAC systems and how to think about that in the school setting. I think there's a lot of cost considerations there that frankly I don't know that we have the answers for yet. So I think there is some consideration for, you know, modifying existing systems or doing some of the intermediate adjustments that could help with improving ventilation. But in terms of like full replacement of systems and things like that, that's not something that we're not, you know, recommending at this time. And then I think I'm seeing some of the chats come through. We're definitely in communication with FEMA around that, recognizing that any recommendations on ventilation systems for schools is a big expense and not something that schools will be able to bear the burden. So I think it's definitely a consideration. I think we still need some more evidence and some more collaboration with our other partners to get a more concrete, you know, steps or phases to consider there. And we can do some more follow-up with our colleagues in that one when we respond back.
Thank you. Murray Cooper wants to know about the effectiveness of dividers at student desks.
Yeah, so dividers are kind of one of those, they fall under that social distancing, that physical distancing strategy. So that might be kind of spacing between students and also kind of that, putting dividers so that it creates that space, even though you might not have people right next to each other.
We had some questions, kind of various forms of this question, but a student becomes positive, indicates that they're positive or they're showing symptoms. What are sort of isolation, sort of quarantine best practices for other students that principals or teachers feel that those students were in contact with that student? What are best practices around that?
So the first thing should be that if a student is showing, anyone's in a school setting is showing symptoms, the first thing they should do is make sure they're wearing a mask. Masks are most effective for what we call source control, that is preventing someone who is sick from getting other people sick. So proper masking is very essential there. And then we do recommend, having a space laid out in a school where you plan where that isolation is going to be, where children can be monitored, but they can be 6 feet apart from anyone. And so it could be, in the office or in the nurse's office, but we really do emphasize that, anyone who's physically present should be masked and they maintain 6 foot distance. So that's the first thing, is make sure the parent is notified, get them referred to a healthcare provider, really get the child care so that they can help to feel better. And then the next stage is really kind of identifying who are those close contacts. And that's where kind of the definitions come in around people who are within 6 feet or less for at least 15 minutes or more. And then those are the children and the individuals who need to be identified as close contacts. We recommend quarantine for 14 days for those individuals, and referral for testing.
So quarantine for 14 days, so that would mean the student who is potentially showing symptoms, as well as those that he or she was in contact with, would have to be should be out of school for 14 days?
Correct. For anyone who's a close contact, we recommend quarantine for 14 days.
Okay. I had a question here from Sharon. She talks about how there's seasonal allergies coming up and flu, and I think referring to flu season and some of that. So how do you sort of navigate all that?
That's a great question. So that's where testing is really important, because you don't want an entire classroom quarantining for 14 days over sniffles because of seasonal allergies. So that's really important to ensure that we confirm that was a positive case. And, there are some symptom presentations that seasonal allergies, flu, that look a lot like COVID, which is why we recommend if anyone has symptoms, they should not come to school. Let's start with preventing it from walking into the school in the first place, and making sure that those colds are not circulating. So when someone does have the sniffles, it's more likely to be COVID than other illnesses.
A lot of great questions coming in on the chat, and as Danny has already mentioned, we're going to do everything we can to get your questions answered. There's several dealing with restrooms in the chat. Any advice, guidance around group restrooms, recommending that students be assigned to certain restrooms to mitigate transmission?
Chris, do you know if we addressed that in our guidance?
Oh, I'll need to go back and double check. I do think that, I think the things that we mentioned earlier, whenever possible, limiting the number of people in the restroom, and trying to have classes that are using a similar restroom. Again, not knowing that that's not always feasible. Let me double check with our subject matter experts on that one to follow up more specifically. Because I think I'm seeing the comments in the chat and appreciate the inquiry about very specific recommendations, and we want to get there too. So
yeah, there was a question regarding how often should elementary children wash their hands? Should the guidance be once an hour, or is there anything that you recommend related to that?
We can check if whether we have that. I mean, generally, you want to wash hands, and I think this is an opportunity to teach children what good hand washing looks like, and make sure that we're teaching those behaviors early on. So I think, Chris, does our WASH group have some guidance on the frequency, or is it just before meals, after meals, those kinds of things?
Yeah, I'll have to, let me follow up with them on specifically related to the school setting. I don't recall that specifically.
Mm-hmm.
Okay, we've had some questions on rapid antigen tests. We had a question about whether they should be accepted, and I don't know what this is, but they asked, should the school only accept PCR modular tests? And Paul from Michigan also had a question about rapid testing.
Yeah. So, rapid testing return results in about 15 minutes. They are what we call point of care tests, in that they're more easily administered. And so they do provide an opportunity to more widely reach people for testing. There are some downsides. So there are more false positives. So meaning some people may have a positive test suggesting that they have COVID, then when they really don't, then PCR tests, which are kind of the standard diagnostic tests. So there are trade-offs in the different strategies. Schools don't have the laboratory facilities to be able to do PCR testing. So if a school is interested in doing school-based testing, it's likely that they would have to offer antigen testing. But it's a good way to be able to offer a service, do some testing in the school if the school has facilities. There's some caveats around who can provide that and which types of school might qualify. Our guidance will address a lot of those issues.
Great, thank you for that. We have time for probably 2 or 3 more questions. Dr. Franks, do you have any on ready to go?
Yes, there was one regarding fogging machines to keep students safe. How often should schools that are using, how often should they use fogging machines?
Chris?
I don't know. So we will follow up on that. I won't even try to give an answer that.
We have industrial hygienists who are experts in this kind of thing, but that's not us.
Are they? Do you know? Are they effective? Do they work? Is it something that you have looked at?
I'm quite sure they've been looked at because I know that there's been discussions about it, but I don't know what the final response is about how effective they are.
Okay, no problem. We had a question about. We talked earlier about exposure with the child sort of in school, and if they show symptoms or if there are interactions with other students. What about the case where potentially a child is in the home with someone who contracts COVID? Tracy asked whether or not, at what point does the 14-day quarantine start? How would you sort of handle that?
So generally 14 days counts from, and the reason, I should clarify, the reason we say 14 days is that we know that there's a general course to COVID where there's a certain number of days where after people are exposed, before they start to show symptoms, and before they even start to have a positive on a test. So if I'm exposed to someone today, tomorrow I get tested, I'm probably going to test negative even though I have COVID, right? So we want to make sure that 14 days gives you that indication of that the whole time has passed. If they haven't developed symptoms and they have not tested positive, probably did not get it. So that applies to whether that close contact happened at home or whether it happened, at a play date, a sleepover, or at school.
And Dr. Franks, want to maybe do you have one more?
I got 2 easy questions here that came up early on. One is, where can principals find the self-evaluation for school's performance that you mentioned, as well as the family game that you talked about?
So once we share the slide deck, as I mentioned, there's little red words at the bottom of each slide, and those are some suggestions for what to put in a Google search term that will help you find those exact links. So I think if you do CDC COVID evaluation schools, that will probably lead you to the right tools. And likewise, CDC COVID parent, that should give you kind of the link as well. Okay.
Thank you so much, folks from the CDC, Dr. Massetti and Jessica and Dr. Jones. This has been really, really informative, and so much ground covered. There's so many things, and I think it is encapsulates what all the questions and issues that folks on the ground are really sort of going through and navigating and trying to figure out, and potentially, in some cases, hearing conflicting information or incomplete information. And so this has really been really helpful. We are going to, for those who, many of you have asked in the chat, and just to clarify, we are gonna, we have this recorded, so we will provide that recording, and we will also have the slides that the CDC here shared. We will have those as well, and so we'll provide those on our website, naesp.org. And I think the only other thing, I don't know if there's anything else you all wanted to mention, Dr. Massetti. Or,
Yeah, I should also mention that we do have an email address. It's like a generic email address. Anyone from the public can send an email and just have a question like, my aunt just tested positive and I had dinner with her 3 weeks ago. Should I get tested? I think, correct me if I'm wrong, Chris and Jessica, I think it's cdcinfo@cdc.gov. Anyone can email at any time. They should get an answer usually within 24 to 48 hours. If it's a fairly straightforward question, it takes a little longer for things that are more complex.
Okay.
And Danny, just to note too that we've captured all the questions in the chat box, and our CDC colleagues have graciously agreed to work with us to provide a Q&A document to try to address many of these questions, and we'll get that done and out as quickly as possible.
Yep, we will do that. And currently on the screen is my email address, dcarlson@naesp.org. So if you think of something tonight while you're having dinner or something and you have another question, just email it to me. We're going to compile it all, and then we're going to send it on to CDC. And they've, like Dr. Franks mentioned, they've offered to pull a Q&A document together for us, and so we'll push that out as well. So thank you all again, and thank you everyone who joined us today, and appreciate it, and stay safe out there. Thanks.
Thank you so much.
Thanks, everybody.